Hello, everybody, and thank you so much for the honor of being able to speak at your meeting. I wish that I could be there in person because, again, I just absolutely have become enchanted with Colombia since my previous visits there. Today, I've been asked to speak about the surgical management and blood-sparing tips and techniques for the placenta accreta spectrum. My name is Karin Fox, and I am an associate professor and the fellowship director for maternal fetal medicine. And I also run the clinical aspect of our placenta accreta care team at Texas Children's Hospital and Baylor College of Medicine in Houston, Texas. For my disclosures, I do have some funding for the use of MRI in placenta accreta spectrum. We're working on developing a national OBGYN REBOA database, and I've been in contact with some of your colleagues about this specifically. I'm a member of the International Society for the Placenta Accreta Spectrum and treasurer of the Pan American Society for the Placenta Accreta Spectrum, two organizations for which I would hope that any of you who are interested in contributing data and collaborative research and education would be interested in joining. The objectives today, of course, are to discuss the essential elements of an effective multidisciplinary surgical team, standardize the surgical approach with the perioperative care in the aid of protocols and checklists, recognize and respond to unanticipated cases, and identify tools and techniques that you can adapt to minimize blood loss and surgical complications. And why this is important, even when we're looking at our most recent data from the United States, and this is not talking about developing nations, we see that placenta accreta and postpartum hemorrhage are always among leading preventable causes of maternal morbidity and mortality. When we look at the graphs here on the right, we can see that over time, this rate of maternal mortality has been rising over the last 2 decades. And in part, this is because of better documentation and actually identifying women who are dying within 1 year of birth. But also we see over time that the rate of adherent placenta or placenta accreta spectrum seems to be rising and attributing to this risk. However, when we look back, we know that placenta accreta has been at play and a part of morbidity and mortality for decades, even since the 1920s. But we do notice that in about 2009, we start seeing an increase. And the reason for this, when we look at this particular study, is the fact that ICD-10 codes started being used in the United States in about 2009, 2010, and they have very specific coding elements for the placenta accreta spectrum, whereas before that, ICD-9 codes do not specify hemorrhage that is due to accreta versus retained placenta versus other reasons, or hysterectomy specific to the placenta accreta spectrum. So we do think that over time, we are going to get better data now that our coding has improved. It's important to understand that while we do think that the surgical definitive management is surgery for placenta accreta spectrum, there are some other alternatives to just doing a hysterectomy. Surgical management, of course, includes cesarean hysterectomy that is immediately performed after delivery. This is considered kind of the gold standard, the ultimate therapy that takes care of the problem, prevents a future pregnancy. However, it can be associated with risks that we'll get into. Some people argue, should we do a total abdominal hysterectomy, including removing the cervix, or a modified radical hysterectomy where we're taking more of the parametria, or should we stop at a supracervical hysterectomy? I would argue that knowing the anatomy and knowing what you're dealing with before you go to the OR can help you make these decisions. A total abdominal hysterectomy, including the cervix, may be necessary if the placental tissue dives very deeply into the cervix. In this specimen here, you can clearly see invasive placenta, lots of bladder involvement, but notice there is a pretty robust cervix, in which case we may have performed a supracervical hysterectomy without adding morbidity or bleeding. However, if you have a patient who has had abnormal pap smears, has had intraepithelial lesions, and for example, a LEEP or a conization that may be due to precancerous lesions, it may be beneficial to removing the cervix to prevent future risk for cervical cancer, or prevent the need for maybe having to go back and doing a tracheolectomy later. Again, it may be wise to do a supracervical hysterectomy if you are concerned that further dissection of the bladder downward will cause additional bleeding, as long as you are past the bulk of the placental tissue. Some folks talk about leaving the placenta in situ with no attempt to remove the placenta prior to hysterectomy. This is very important because if we do pull and tug on the placenta, we can cause massive hemorrhage that may occur vaginally. And then, of course, there could be a delayed completion hysterectomy where the placenta is left in place, not moved, and then anywhere between 3 to 18 weeks postpartum, a hysterectomy is completed, with the idea that perhaps we can have less blood loss once the placental vessels and feeding vessels have had a chance to retract. One must use caution, however, because bleeding and infection and DIC may ensue at any time, and teams need to be able to respond, and patients need to be able to understand when and where to go to the hospital. There is also the surgical conservative management that we'll talk about briefly, but this surgical management with hysterectomy is considered definitive therapy. Now, true conservative management, when we leave the placenta completely in situ, the goal of this is to truly reduce surgical morbidity, to preserve the uterus, and to allow the placental tissue to just either resorb or be expelled. Now, the median time for this to occur may be as long as 6 to 9 months. Patients who undergo this type of therapy complain of heaviness in the pelvis and sometimes a very unusual and sometimes not very pleasant discharge that is brown, and parts of placenta may come out. And oftentimes the cord may actually then prolapse through the vagina and cervix, and with a small tug, the placenta will deliver. Now, this has been shown to be effective in some patients. It is fertility sparing in patients in whom it's successful, and 70 to 88% of patients may conceive after having this kind of therapy. So while fecundity is a little bit lower, they can still deliver, and most go on to have third trimester or term deliveries. The important thing to note is that the risk for recurrence is still 22 to 28%. If one has had accreted previously, they are at risk for it again. And anywhere between 20 to 58% of women undergoing truly conservative management may still need an emergency hysterectomy. Uterine sparing surgical techniques. This is actually, I think, there's very robust data, especially from Dr. Jose Palacios Harquemada out of Argentina, and some other groups in England, for example, using the triple P procedure. And we have done some of these cases as well using a uterine sparing surgical technique. This is a technique that, again, the goal is to reduce surgical morbidity, potentially to maintain fertility because the uterus is spared. And the goal is to resect out the portion of the myometrium that is affected by the placenta accreta, with the goal to repair the uterus together. Now, it is not possible in all cases. We do have very robust data for that. Again, I would encourage folks to look at the paper by Dr. Palacios Harquemada, in which over 200 cases are reported. When the placenta dives down deeply into the cervix or bulges laterally into the sidewalls where the feeding vessels are, those are the patients in whom it may not be feasible to do a focal resection. Another expert with whom I've been working lately, of course, has had the insight, and very similar to Dr. Palacios Harquemada's statements, there really needs to be a little bit of tissue on the lower edge near the cervix that is healthy tissue to which to repair. But if one is able to get underneath that area, find that focal area of invasion, it does require dissecting down the bladder quite fully before hopefully making a high transverse incision above the placenta rather than a fundal incision in the placenta, and then resecting out that area of the placenta that is affected down below, and then repairing the uterus together as though there's a wide hysterotomy. And this can actually be quite effective without much higher blood loss. However, one must still be prepared for heavy bleeding and the need for transfusion if necessary. And finally, cesarean hysterectomy, which we've discussed. Again, what is still controversial and is up for debate and a topic of ongoing research is whether or not ureteral catheters are truly protective, or if they just make us feel better because we can identify the ureters more easily. Whether or not a cystotomy is necessary, again, some experts believe that a cystotomy is certainly better than having massive bleeding, but we truly don't know what the long-term effects of having a cystotomy are in the setting of placenta Creta spectrum. We have lots of data that suggest that after radical surgery for cancer, that the bladder does tend to repair and return quite close to normal, but we don't have solid data as yet. Now, the surgical techniques, whether uterine sparing or radical hysterectomy, require a strong surgical skill set and do have an association with a higher rate of urinary tract morbidity. Now, again, one thing that I think is really bearing out a lot of evidence and that we are really encouraging folks to do is that we've had a clear shift from the single expert surgeon to a multidisciplinary team management approach. There are probably some rare centers where a single expert is sufficient, but really we cannot do what we do even as experts without a whole lot of help. And this ranges from having diagnostic expertise, whether it's using ultrasound or MRI, having access to care 24/7 and a plan for emergencies, having standardized plans and checklists that help others who may not always do these cases understand how to at least get things started and know who to call. And of course, having all of the requisite team members, such as an anesthetist, ICU, critical care, transfusion medicine on board. And of course, we would argue, including quality improvement and safety and research into your management team. And why should we have a team or teams? We know that when we share our experience and share our knowledge, we learn from one another and we can gain expertise and experience. It does require the willingness to have those two-way conversations and help one another out. We also know that this helps us when we have multiple people who are involved. It helps us provide adequate 24-hour-a-day, 7-day-a-week coverage because everybody needs to have a vacation from time to time. Emergencies come up and we cannot be everywhere at once. And we have found, for example, in our cases that up to 46% are unscheduled. When we work together repeatedly as a team, this also helps us maintain competence and our team dynamics, but also it can help us allow a trainee, a learner to come in, work with experienced people and gradually learn as they're becoming one of the team, which can help us maintain our resilience and our long-term capabilities. And again, one very important thing is when we're working together as a team using one unified approach, this helps reduce variation that may occur when Dr. X does things one way, Dr. Y does things another way. And we know that when we reduce variation, we can increase the quality of care because all team members are on the same page. Now, this example on the right that I'm showing you shows that it doesn't matter so much how many team members you have or what their actual titles are. What is most important is that when the team comes together, that the collective skills are present for everything that you need to do to execute that mission. So for example, in the top, there may be 9 team members, and on the bottom, there may be more like 6 team members, but together, each of the teams are capable of doing and executing all of the functions that are necessary to take care of somebody with placenta accreta spectrum. Another thing that's very important is when we're talking about growth and sustainability is determining and using some really good data collection and the knowledge of how teams and learning function to kind of monitor the ups and downs that occur with any kind of growth. So for example, when you have a new program, you have a champion, somebody's doing things, you get a lot of momentum and make some forward progress, but then you have a little downturn and things seem to backslide a little bit. But maybe then you create a new initiative where, for example, not only do you have an accreta team, but maybe you're then doing quantitative blood loss so we can keep better track of blood loss and get on top. And as we educate more people, get our nurses and our circulators involved, then we have a little bit more growth. And then maybe we do some simulation training and improve things again, start having some formalized feedback, and we get better and better and better over time. But there is this cycle of growth that is not linear, and we need to make sure that we continue to move that growth forward. If we stop actively working on our team and on our programs, we may backslide completely and then be back to square one. What we want to do is maintain that growth and then ensure that we continue, once we hit a very good point where we're really working well, that we maintain our sustainability and keep things going forward over time. Now, one thing that can really hurt the sustainability is when we have team turnover. If people leave our team, people get promoted, they go to new jobs, you have to find somebody else to take that place, and that's where you may have to really, regroup and get things going again and repeat some of these steps in order to ensure your growth and sustainability. Again, we are repeatedly what we do. So excellence is not an act, but a habit. So getting forward and doing things very well, even the little things over time, is really important. And this is what has slowly but surely helped our team get better and better over time. And so we've noticed when we look at our data, and we look at the data from others, that all of these complications are decreased for the most part, not maybe all of them, but the ones that we can count frequently, the frequent events, are decreased when we use a multidisciplinary team that consciously makes an effort to make iterative improvements in their work over time and then grows and learns together. And this includes blood loss, transfusion, massive transfusion, ICU admission, and the need for reoperation. The other things I would argue probably do also decrease, but because they are relatively rare events, it's hard to get clear data until we have more multidisciplinary and multi-center studies. Again, if you've heard me talk before, I really advocate for the use of standardized checklists. This helps everybody make sure that all of the things that we need to know about are addressed, and it can serve as a nice means for communication amongst multiple team members. The checklist on the left is one that is oftentimes used for diagnosis and reporting of placenta accreta using a standardized ultrasound form. It is not the only form that is out there, but I find this particular one very useful because it incorporates clinical risk factors, ultrasound findings, including to color Doppler, and then at the end, it asks the person reading the ultrasound to actually make a determination: is there a high, middle, or low risk for focal or diffuse placenta accreta? The other two are some checklists that we've developed locally at our hospital for the nurses to use. The one in the middle that is pink is one that's on paper, so that even if the computers aren't working, we can make sure that we have the names of the consultants, what consents have been done, most recent labs, and a checklist. The one on the right is one that we've put into our electronic medical records. So you can see this is one that shows some examples of what are the ultrasound findings, how many C-sections does somebody have, when are they getting admitted to the hospital, and who are the surgeons? And this helps our team continue to know what we need to work on as we get our patient prepared. We've also started putting a medical alert bracelet that I've just pulled up here in the middle on the bottom that a patient can wear if they're at home and they have an emergency. This says on the bracelet, this is a pregnant mother who has placenta accreta and has our phone number on it, so that if the patient is picked up by ambulance and they go to another hospital, somebody knows immediately exactly what is going on. So again, our goal is to avoid those emergencies. So when we look at our patients, we want to time the delivery as soon as possible. We used to routinely deliver between 34 to 35 weeks with no amniocentesis. We know now that there are some patients who may be very stable to go to 36 or 37 weeks. No bleeding, no contractions, not a big massive accreta, or they're in the hospital where we can watch them closely and respond quickly. There are others who have risks for preterm birth. They've already had bleeding. They live very, very far away, and they might be at more risk. So some patients may need to deliver early. And as I've mentioned, about 46% of our patients do have indications for early delivery. So the goal here is to balance the risk of maternal mortality and morbidity with the risk for prematurity for the neonate, with the focus knowing that an emergency for the mother is surely an emergency for the neonate as well. So again, we've really standardized a lot of our other processes, including anesthesia planning. So we always want to have IV access to big IVs, a rapid infuser and warmer that can warm the fluid that is going into the patient to prevent hypothermia, arterial line placement for continuous monitoring and blood support. We used to use general anesthesia rather, putting the patient to sleep from the beginning of every case, but we now know that that women can tolerate a regional anesthesia, such as an epidural. But the risks are, if you have somebody who might have a difficult airway, or they're bleeding, or they're so anxious that they can't tolerate the epidural, it may be best to use a general. If the patient is already bleeding and it's an emergency, it is truly best to go to general anesthesia from the start. The benefits of an epidural are the patient is awake for the delivery, the family can be there for the delivery portion, the baby is much more vigorous at birth, and it's highly satisfying to patients. And it can be used then for postoperative pain control. Again, some things are not novel, but they still are very important to address. We truly encourage every facility that will be caring for women with placenta accreta or complex surgeries to have a massive transfusion protocol. This is an example of our protocol where we clearly define roles for people who are responding. We have all of the important phone numbers on this list, and it kind of gives some guidance of what will come. Red blood cells, FFP, platelets will come, and what labs will be drawn. And then the blood bank knows to continue to send blood until we cancel the massive transfusion protocol. We have labs, packs that nurses can use to draw labs, take directly to the lab. And if the lab receives that pack, they know to stop everything else and run that lab immediately and give us the results. It's equally important, if not more so, to plan for patients who refuse blood transfusions or for whom there is no available blood. So individualize this treatment plan. Make sure you are treating anemia early. Consider a cell saver or normovolemic hemodilution or vascular occlusion, such as with a balloon catheter or otherwise. This is an actual photo of normovolemic hemodilution. This is not new, but it has been used and it can be very helpful. This is where you take a blood bag, usually used for blood collection, and you attach it to the patient through an IV and you draw off 1 unit of blood. Once that unit is drawn, you replace 3 times the crystalloid. And you see we have the stopcocks here aligned in series. So this first bag of blood is then secured with a stopcock. Oh, let me back up. Then once that unit is taken off and fluid is given, a second bag is taken off, fluid is given again to resuscitate the patient, and then the third bag is drawn. And then what happens is these are stopped, but as we start our surgery, if the patient begins bleeding, we can then start with the most dilute bag and give that back to the patient, and then save the most concentrated bag that will have the most factors, fibrinogen and platelets in it, and save that for the end. And as long as we do not break the circuit, many patients, even who refuse blood because of their religion, maybe they're Jehovah's Witnesses, they will accept blood this way, and it can be very useful if you do not have a cell saver, and as long as the patient's hemoglobin is reasonable at the start. You would not have time for this, for example, however, if a patient comes in actively bleeding, that would be somebody who needs a transfusion. Again, I've mentioned the standardization and the checklist. Other things that we do at our center is we have a cart, such as the one I'm showing on the left, that has all of the equipment you would need for a cesarean hysterectomy, including ureteral stents and the urology equipment. And there's a list that shows exactly what is on what shelf. That way, whatever nurse comes into the case, if we ask them to go grab supplies, they don't have to go searching for it far and wide. It should all be centered in this case. We have standardized positioning in movable stirrups, as you can see here in the middle, which allows us to do cystoscopy and stent placement easily. It allows us to watch for bleeding from the vagina very quickly, and it allows a third surgeon to stand between the legs so that we all have access to help with the surgical field. Again, we've got some ureteral stents here that I'm showing on the right, and the potential for a Reboa catheter, which you can see going up here, not inflated, but use of interventional radiology techniques to help reduce bleeding. Again, another standard that is not new, but very important is whatever you do, do not poke through or cut the placenta. One finger through a very tense blood-filled placenta can lead to massive bleeding. And the other very important issue is just to understand that knowledge of the anatomy is critical. When you know the anatomy well, you're much less likely to injure it, but also anticipate the normal anatomy may be distorted. A big invasive placenta like this can sometimes draw the ureters up. They may be engulfed by the placental tissue where the placenta wraps over the ureter. And so having a thorough knowledge of that and meticulous surgical technique can actually help reduce blood loss. Again, a couple of surgical techniques that we've shown before are the use of electrocautery and making sure that when you're making your hysterotomy, you make it well away from the placental tissue, which is much lower here. We've got an obese patient, but then also you're either using a linear stapler cutter that seals the edges and cuts the myometrium, or in this case, we've used bovicautery to open the myometrium, but placed 2 fingers inside, elevated the myometrium up, and as we're opening the uterus, our assistants are placing these clamps all along the sides to help keep those edges from bleeding. And you can see there's absolutely minimal blood loss here, but plenty of room through which to deliver a baby. And then, of course, we put which I think I have here. Yes, we place the cord inside, and while wanting to seal the membranes to the edges with a suture so that we can reduce blood loss. Other surgical techniques and new devices that have been very helpful, of course, using electrocautery works sometimes. However, in order to get nice big bites, we can always use something like a ligature device, which helps seal and cauterize and then cut through pretty large vessels. You can get up to a 7 millimeter vessel. In these cases, these are quite large. So we've sealed them 3 times before cutting, and then we move down the uterus as we go with care to avoid the major arteries and the placenta in the process. This is the posterior side of the uterus, so you don't see the placenta here. It's on the other side. Again, we've also shown some techniques about how to identify the ureters and the fornix when taking out the uterus. You can see here the ureters in this video are already dissected out and on vessel loops. So anything medial to those structures, we will not injure the ureter. But we also know that we can place this EEA sizer in the vagina, this metal piece that helps us identify the fornix and avoid taking out the upper vagina, so we can preserve the vaginal length even if we are taking out the cervix. Again, surgical technique is really crucial here. It's important to use very slow, deliberate technique. Notice here the hand is on the uterus and placenta, which may be dangerous, but with very gentle touching and very gentle pressure, it may be okay. Notice how tense this very lateral bulging placental tissue is, again, wrapped around a ureter. Again, recognizing and managing hemorrhage is crucial. It's very important to make sure that we are checking frequently for hyperkalemia, hypocalcemia, replacing blood at a 1:1:1 red blood cell to fibrinogen to platelet ratio, and make sure that someone, a nurse or an assistant, is checking below the legs every 15 to 20 minutes to watch for hidden vaginal bleeding, because sometimes your abdominal surgical field may be pristine and clean, but you can still have a massive blood loss from the vagina if you're not careful. Again, some of the basics, the lethal triad include coagulopathy, hypothermia, and acidosis, and this can lead to very rapid deterioration. So we want to interrupt bleeding before we hit coagulopathy, but simply by keeping the patient warm, using an air hugger, keeping the room warm, making sure that fluids are warmed can go a long way. Using novel methods of looking at clotting functions such as TEG and ROTEM can also help guide your transfusion and make sure that you're only giving what you need without just giving massive amounts of blood product. But again, this also depends on the pace at which blood is being lost, whether or not that works. Again, as far as recognition and management of hemorrhage, it goes back to stopping the bleed. There are some novel laparotomy sponges and sealants that are very useful. The two on the bottom, the Quick Clot is a trauma pad that was designed for the military. It has kaolin that is absorbed in the laparotomy sponge, and kaolin, when it contacts blood, helps activate the coagulation cascade without generating too much heat. Celox gauze is very similar, but it has chitin embedded into its sponges, does the same thing. Both of these devices, the sponges must be removed from the abdomen. These are not things to be retained just like any other laparotomy sponge. This fibrin patch sealant, this is very much like cellulose. It is a cellulose matrix that can be absorbed that helps create a scaffolding for clotting factors to build a clot. It also is embedded with fibrinogen powder and thrombin powder. So if you put this on a bleeding area, hold pressure for 3 minutes, it can actually stop bleeding on a liver or an aortic laceration quite effectively. It's almost like a patch. Don't forget that tamponade balloons can be used, whether it's a good old-fashioned condom on a catheter or something as fancy as an Ebb balloon. And these can be used inside the uterus or in the pelvis after the uterus has been removed. Aortic occlusion, while this has been around for a long time, since 1922, we certainly don't want to tie off the waist of our patients anymore. But because these are really non-compressible, it goes to either using something like an aortic balloon occluder, such as a Reboa catheter. There are other newer devices that are smaller that are being developed that may also do the same thing, or cross-clamping with a clamp, or even using manual pressure can absolutely save a patient should rapid bleeding ensue. I have here an example of a patient who I delivered with one of our fellows, one of our trainees. She had 4 previous C-sections and a FIGO grade 3C pelvic sidewall involvement in the left parametrium, and she had a Reboa catheter in place. Now, we usually have another surgeon come in and manage that balloon if we need it inflated, and we were doing just fine with minimal blood loss until we had someone put a clamp into that placental tissue near the parametrium. And you can see here in her labs that she started having very precipitous bleeding as soon as that clamp went on. And so I asked our nurse to call the surgeon. In the meantime, I asked my fellow, give me aortic tamponade and pressure with your hand. And she did manual pressure. And you can see here, her manual pressure was so effective that in that Reboa catheter that also acts like an arterial line, you did not see any flow for about 3 minutes. This gave time for our anesthesiologist to catch up with resuscitation, and we were able to get control of the bleeding vessel. And by the time the surgeon came in to inflate the balloon, we had already gained control. And he said, you don't need me in here to inflate that balloon. And I said, no, we needed you 2 minutes ago. But even this can act as a very rapid, easily accessible means to control bleeding. Again, I've put in here also a summary of the FIGO recommendations of resource settings that we recommend that you have and what should be included. I will leave these for your perusal. I will not go over those now for the sake of time, but the take-home messages are that using collaborative multidisciplinary team-based care really does improve outcomes. And if you do not have a team, develop one or get patients to a center that does. Plan early and be prepared for an emergency. Don't wait for it, but be prepared for that emergency. Preparation, planning, standardization, and experience are truly the keys to success. There are a lot of us out here who really want to help give advice when possible. And do try to look for protocols and checklists that you can adopt and adapt to your center. And with that, I thank you so much. I'd like to leave you with these resources. These are the websites to those organizations that I mentioned. And there's a very nice placenta accreta spectrum video set and some resources in Spanish that you can give to your patients and referring providers. Thank you so much for your attention, and thank you again for the invitation to present.